Hello, I'm Dr. Masood Khan. Today we will discuss a long case, history taking examination, and further discussion of this long case. So my patient, Mr. Atif Shehzad, son of Akib Shehzad, 13 years young boy, class 3 student, resident of Lahore, admitted through emergency on 10th of June 2024 with presenting complaint of fever 25 days. The fever is gradual in onset, intermittent in character, high grade but not recorded, associated with rigors and chills. Progressive in nature for 25 days, aggravated by activity and relieved by syrup paracetamol. Fever is associated with nighttime cough and shortness of breath, sore throat, flu-like illness. The shortness of breath is gradual, progressive, unable to walk and perform regular activities, restricted to his room since last 10 days. Patient complaint of cough, which is dry, occurred at night, sudden in onset. He was unable to lie flat for some days and is unable to sleep since last 4 days and remain in sitting position since last 4 days. It was not associated with any chest pain, palpitation, any valvular heart disease, dental procedure, dental abscess, any drug abuse. There is no history of bleeding from any orifice or any high-risk sexual behavior. Patient denied any history of whistling sounds, inhalers use, birds at home, factory fumes exposure, no history of any altered sensorium and fits, any redness and dryness of eyes, any discharge from the ears. There was no history of tuberculosis contact, night sweating, low-grade fever, altered bowel habits, any lumps and bumps, weight loss, and skin bruisability. Patient denied any history of joint pain, deformity, oral ulcerations, muscle weakness, photosensitivity, no burning micturition, genital ulcerations, itching or any discharge at the genitals, no history of heat intolerance or cold intolerance. There is no history of pain in right hypochondrium or abdominal distension, prolonged use of antibiotics, anticonvulsants, no history of any bony part, prolonged immobilization, decubitus ulcers. There is history of using tap water. He has repeated childhood infections for which he took multiple symptoms and IV antibiotics prescribed by local doctors. History of contact with kettles and is positive and lives in rural Kacha house. No history of monthly IM injections. No history of any pink induration with central clearing. No any painless nodules over shins or tendons. No any abnormal upper body face movements. No joint swelling, deformity noticed. There is no history of sudden vision loss or weakness of any part of the body. No history of penile ulcerations, frothy urine, yellow discoloration of sclera, sudden loss of consciousness, and blood in urine. During hospitalization, different tests are done, including chest X-ray, ECG, and echocardiography. Patient is informed about some valvular problem. The blood and throat cultures are also sent and awaited. During hospitalization, multiple antibiotics, IV injections plus deep IM injections given, but patient is unaware of their names. He has no history of any drug allergy. There is one brother and one sister, both are healthy. Parents are both alive and healthy. Father of the patient works in farm with cattle, and there is 4 rooms in which 5 family members live. There is no significant travel history. There is no transfusion history. The EPI expanded program of immunization vaccination completed. COVID-19 vaccination is given to the patient. Patient is very depressed about his condition and lethargic. On history basis, my differential diagnosis in this young boy with fever of more than 1 month, with rigors and chills, my differential includes acute rheumatic fever, brucellosis, and infective endocarditis. On examination, a young boy lethargic, lying on bed, not cooperative with doctors and nursing staff, with IV cannula in right hand. His vitals include blood pressure 100 by 70 millimeter of mercury, temperature 99 degree Fahrenheit, respiratory rate 20 per minute, heart rate is 96 per minute, regular, good volume, normal, catastrophic character of the pulse. On general physical examination, hands, it's pale and dry. There is no cyanosis, no clubbing, no ocellular nodes, no splinter hemorrhage, no bruises, nodules, and skin rash. JVP is 3 cm above the sternal angle. No yellow coloration of sclera, oral ulcers, no lymph node palpable in axilla, inguinal region, abdomen. However, there is mild pedal edema, positive bilaterally. Cardiovascular system includes the visible cardiac impulse in the left inframammary region and epigastric region. No deformity of chest, scars over chest or veins over chest. Apex beat is palpable in the left 6th intercostal space, lateral to midclavicular line, thrusting in character. Left parasternal heave is palpable P2. S1 plus S2 audible in respective positions. S1 is soft, harsh pansystolic murmur radiating to axilla with 3 by 6 grade, heard best on left lateral position with breath held in expiration. The pansystolic murmur is also felt in the left lower sternal border, radiation across the sternum, and its intensity is increased on expiration. P2 is loud, lung feels difficult to auscultate, no other signs of infective endocarditis. The CNS and GIT examination is unremarkable. So patient is now established rheumatic heart disease patient, because there are 2 murmurs. One is MR, the pansystolic murmur, which is radiating to the left axilla, and the tricuspid regurgitant murmur, which is best heard at the left lateral parasternal border. Now, question: if IM benzathine penicillin is not available, what is your choice of antibiotic in a patient of rheumatic heart disease? The answer is azithromycin per oral or erythromycin per oral lifelong. Now, a question is that why this patient is having rheumatic heart disease. The answer in this patient is that there are risk factors, the socio-economic conditions, repeated childhood chest infections, unhygienic conditions. Now there is a criteria that is major criteria, the migratory joint pains. That criteria is Jones criteria. I will certainly ask during my history that do you have pain in large joints of the body one by one? When one big joint pain settles, then other big joint pain starts. There is redness and swelling of and pain in the joint. Now this is migratory joint pains in large joint. The other includes criteria is after arthritis is erythema marginatum, rash with central clearing. Now what are the painless nodules in rheumatic fever? Painful nodules or painless nodules. So painless nodules in rheumatic fever, while this painless nodules in rheumatic fever or painful nodule in rheumatic fever. Both can occur, but painless nodule is erythema nodosum, while painful nodules in rheumatic fever. Chest pain and palpitations, it shows valvular lesions, chest pain and palpitations. Now minor criteria includes fever, and there are certain complications, associations of rheumatic heart disease. First complication is mitral stenosis. So mitral stenosis can occur with rheumatic heart. The most common one, mitral regurgitation can occur, and tricuspid regurgitation can occur. Now let's focus that mitral stenosis, if present, there is pink frothy sputum. There might be syncopal attacks. There might be heart blocks, yellow discoloration of sclera, or blood in the urine. MS and MR both as complications of rheumatic heart disease at the age between 35 years and to 45 years they can present. So these are the complications of rheumatic heart disease. So history of childhood fever is often forgotten in 60% of cases when they visit patient for mitral stenosis or mitral regurgitation cardiac visit. Oh, thank you very much. Thank you very much.